Thank you very much for that introduction. So let me first of all to say thank you for the organizing committee for inviting me to give this James Hakim memorial lecture. James Hakim was one of my colleagues, friend, and PI under the MEPI program. So it's really an honor to be here. So I'm going to talk about the Mpox. And the roadmap somewhat is going to be, I'm going to go from historical perspective to allow you to understand where we're coming from, why are we here. And from there, I'm going to say what, mostly through the leadership of Africa CDC, how we are trying to make a difference. And finally, I will finish with some touch of our own group research on Mpox. This is a DNA virus. Which has been there for some times. And it belonged to a family, to the same group of smallpox. As you know, smallpox was eradicated in 1980s. So here we are. There is two clade 1 and clade 2. Clade 1 mostly in Central Africa, clade 2 mostly in West Africa. And the virus was actually discovered in a captive monkey in Denmark, the monkey that were imported from Singapore in 1958. But the first case actually was diagnosed in human in a 7-year-old boy in the Democratic Republic of the Congo, where I'm originated from. And some of the slides I will be showing today, I owe them to my colleague and collaborator, Professor Jean-Jacques Muyembe, that most of you know from DRC, who co-discovered the Ebola virus. So as you can see, it's a very stigmatizing disease with those rash on the face. In terms of the pathogenesis, so the virus, basically, it's been the suspicion that the reservoir is in a non-human primate or in some rodent. You get exposed through those, and through the skin, it distributes through your body, and the transmission is basically can happen really easily through contact, physical contact, sexual contact, droplet by food, vector-borne, and recently, sexual transmitted is known now as a sexual transmitted disease. The respiratory tract, skin, mucosa, or placenta can be involved. So it's basically end up to be a systemic disease of particular importance, and that's why there is need to talk about this at the HIV conference. Immunocompromised really have high morbidity and mortality, so HIV/AIDS, pregnant women, young children, and all other immunocompromised are really at risk. Basically, after exposure, in terms of the natural history, you have about a week or two of incubation, and then you have a prodromatic symptom, like flu-like symptom, for about few days, with headache, fatigue, and more common is lymphoadenopathy. And then follow about 2 or 3 weeks of a rash, which most of the time start on the face and then distribute centrifugally on foot, hand, arm, and so on, and which end up to resolute, but with really scaring and sometimes complication. We can go through, most of the time, bacterial complication, pulmonary involvement, severe dehydration, diarrhea, encephalitis, visual loss, and death. Clade 1 has the highest mortality, up to 10%. Clade 2 is less than 3%. So you can see those stages of the skin, which start like just a vesicle, pustula, and then desquamate. It's very typical. In the Democratic Republic of the Congo, where the first case was diagnosed, children at high risk. Why? Because they used to go to play in those deep forests and they get exposed to wild animal or those rodent activity like trapping, hunting, handling of bushmeat, dead rodents. Squirrel are being at high suspicion of being actually the vector, but until now we don't really know what the exact vector, it's just suspicion. So you saw all the exposure to bushmeat in our country. It's quite common. And then during those years, from 70 to 80, there were just some sporadic cases, not just in DRC, but in Central African Republic, in Cameroon, in West Africa, Cote d'Ivoire, Nigeria, but at really low level of cases. I recall even in DRC, there was some ongoing active surveillance. If you're able to diagnose cases, you get a reward of monetary reward. And WHO actually, after they admitted that smallpox no longer cause a threat, even if there was some small case of monkeypox, it was not a big deal. From that slide, you can see actually a group of WHO working group where you can see at the front Jean-Jacques Muyembe. So when Muyembe talked about this, he said at that time we didn't know that this is going to become a big threat until through a collaboration with colleagues at UCLA, they really did a fantastic study published in PNS showing that over a decade, cases were just rising, and especially in the deep forest compared to savanna, obviously where exposure is more frequent. And so there was about a 10-fold, actually a 20-fold increase over that period. That was just dramatic. And they were wondering what's going on. As you can see on this slide, again, children were the majority of the cases. So historically, this was a zoonosis by exposure to those, to the vector through those animals, and the children were at high risk of complication of death. But things going to change over time. But as you can see here, really high morbidity, mortality in children. So just a small break, 1 second, as a clinician in the room. The differential diagnosis in those settings, obviously, it's varicella, chickenpox, herpes, hand and foot mouth disease, secondary syphilis, scabies, disseminated vaccinia. So those are most of the differential you need to exclude. I don't have time to go in detail, but just to say mother-to-child transmission, it's a reality. And then the first case was, again, the group from INRB with Muyembe, Placide Mbala, who documented them because of the risk of pregnant women. And then moving from DRC to West Africa, you can see also West Africa, something was going on there over time, over the years, which this is slide by Prof. Ogoina Dimi, showing over time things were also boiling there, and that actually gave rise of a few cases that were unusual cases. So here we're talking in Nigeria of clade 2, and who they seems to have an unusual clinical presentation of sexual transmission. I told you this was mostly a zoonosis, now it's human to human. And then there was some case of a patient from UK who, after returning to UK, also passed it to other in those countries. So look here, this is something unusual. The team in Nigeria really well documented. And as you can see from those slides, this is not what I told you from DRC in children. This is now a full-blown sexual transmitted disease, and which in July 2022, the WHO director declared the first public health emergency of international concern because of those index cases that ended up in UK and the US later. After several months, was over the world. So this was another somewhat pandemic from Mpox. that no one really saw coming, which the response was really energetic from a neglected disease that was diagnosed in DRC in 2017. Nobody was caring about it. You have to wait until it reached the UK, the US, the same story, that to invest a lot of diagnostic tool, a lot of vaccine. And actually, this 2022 global outbreak was shut down in few months. Besides that, it was sexual transmitted. The epidemiology, it was men who have sex with men, was a very circumscribed demographics. So it was somewhat also, actually also with behavior change, it was easy to control. Let's go back to DRC. In meantime, so this is, before we get to DRC, so this is the case in men who have sex with men. You can see really ulcer at genital, at oral mucosa, and some HIV people with low CD4. There was really very necrotic lesion, as you can see here. Necrotic lesion at the skin, at the mucosa, genital mucosa, but also necrotizing pulmonary involvement. So this is why really you need to diagnose this in immunocompromised and HIV people. Going back to DRC now, in meantime, DRC and Central Africa were also in parallel. So going back to clade 1, they were also showing increased dramatic of cases that WHO in 2023 did ring the alarm. And this is showing you our group. We were able to identify that this was no longer the classical historical clade 1, and our group, our collaboration with INRB, led by Professor Muyembe, we identify a sublineage which we name clade 1b in contrast with the historical 1a. Also from Nigeria, the case clade 2 was named clade 2b in reference. So this slide from CDC showing the progression over time. As I speak, clade 1b did spread beyond DRC to Rwanda, Uganda, Kenya, and beyond. And the clinical presentation is somewhat different from the classical when you compare clade 1b and clade 2b, as I show you here. The diagnostic, the gold standard is a PCR, classical PCR, RT-PCR. GeneXpert is most usually used with a specific cartridge. And the problem with GeneXpert is it does not detect which clade it is. You need a specific diagnostic tool for clade, which is the Radion, which is we are using for research. In terms of prevention, we have a vaccine. In correlation, because of cross-immunity with smallpox, we have a vaccine for smallpox. We've been using for proxy for vaccine for Mpox, and it's been able to control the 2022 outbreak. But we still need a specific study for documenting efficacy in different high-risk groups. Treatment, INRB has been leading also a clinical trial funded by NIH with the tecovirimat. It's just been published in England Journal last month. It was a negative study, so we still need really effective treatment for Mpox. We have RNA vaccine on early phase development, phase 1, both Moderna and BioNTech. So this may take another 2 or 3 years. So in meantime, in community, Africa CDC is doing community intensification of surveillance. They are doing great job in terms of IPC. Also in terms of decentralizing lab with GeneXpert. And also vaccine, we still short of doses, but DRC has been prioritized. The current armed conflict in Eastern DRC are making things difficult, but there's been some steady progress. So let me just finish in the next 3 minutes with what we've been.
Less than 1 minute because you're down
Correct. With what we are doing, we created a consortium to try to address this issue. Really a very aggressive research agenda, very comprehensive, with a group of collaborators led by INRB. And at time as I speak, we have a funding from Wellcome Trust to try to address the genomic, epidemiologic, clinical, immunological outcome of Mpox. So this is in 3 countries, DRC, Nigeria, and Cameroon. It's going to aim really to characterize what is not known from this disease across clade 1 and clade 2 in those countries. We have an aggressive research agenda, 2 R1 submitted, both in pregnancy and also in adults. And we just, in terms of capacity building, to create the next generation of young investigators, we have a D43 in DRC, led by Jacques Muyembe, which just recruited 22 fellows who are going to invest in those emerging infectious diseases. And I will just finish by showing this. We are part of the Africa CDC emergency consulting group, where Lucille Bloomberg and a few others here are part of, and Slim Karim. So I'm going to stop here and thank my collaborator in DRC, in South Africa, at University of Pittsburgh, Johns Hopkins, and my founder, NIH, and Wellcome Trust. Thank you very much.